Good afternoon, everyone. On behalf of Unigenome, a division of Unipath Specialty Laboratories Limited, a leading provider of comprehensive genomic services, I, Dr. Monica Darji, General Manager for Scientific Marketing for Rare Disease and Reproductive Division, welcome you all to today's webinar titled Decoding Couple Carrier Screening in the Genomics Era, what every reproductive specialist needs to know. As we know, genetics is transforming the landscape of reproductive medicine, enabling you to move from reactive treatments to proactive interventions. Today's session aims to empower reproductive specialists like you with actionable insights on couple carrier screening, a tool that holds the potential to prevent a wide array of genetic disorders, paving the way for healthier generations. Before I welcome the speaker, let me go through the housekeeping rules. All attendees, except for the speaker, will be on mute during the session and will be very happy to address the questions at the end of the presentation, which you can type in the Q&A box throughout the session. Now, let me introduce Dr. Richa Soni. We are honored to welcome her on the Unigenome platform for an insightful session. Dr. Soni's impressive credentials include a DM in medical genetics from All India Institute of Medical Sciences, Delhi, and an MD in pediatrics, coupled with 8 years of clinical experience. Dr. Soni has been at the forefront of diagnosing and managing complex genetic disorders. Her illustrious journey includes serving as a consultant medical geneticist at Fortis Memorial Research Institute, Gurgaon, where she has spearheaded specialized genetic clinics in neurogenetics, cardiogenetics, and reproductive genetics. Dr. Soni is renowned for her groundbreaking contributions in the field, which includes key contributions in pioneering gene therapy for spinal muscular atrophy patients in India, performing fetal autopsies for precision diagnosis, and delivering compassionate genetic counseling to families navigating through rare disorders. Currently, as an adjunct faculty at ESIC Faridabad Medical College, she continues to shape the future of pediatric and genomic medicine through her work in rare diseases and cutting-edge treatments. Join us for this exceptional session where Dr. Soni will demystify the nuances of couple carrier screening and guide us. So, the floor is over to you, ma'am. Thank you.
Thank you so much for the lovely introduction. So I warmly welcome you all to today's webinar. So today we'll be discussing about couple carrier screening. So this tool enables us to make better reproductive decisions and to make a better life, a better future for the families. So why we are talking about couple carrier screening? Millions of children are born with genetic disorders daily, but these children are born to couple who are completely normal. They don't have a family history. They don't have any disease. So why do these children, they land up with genetic disorders? So here, this testing of couple carrier screening helps us to know what exactly is happening in our genome, why and how, by chance, any person at any point of time can have some mutation and they can be carrier of some mutation, and these mutation can go on to the next generation. They can cause diseases. So in this webinar, we'll be discussing about what exactly is a carrier, what is carrier screening, who needs carrier screening, and what are the methodology which is used to detect the carrier status of a person, and when to go for a carrier screening, what are the guidelines, and what are the clinical implications of this testing. So what is a carrier? A carrier is a person who has inherited a recessive mutant copy for a genetic trait. So these people are often asymptomatic. So they don't present with any disease. They are completely normal, but they have the tendency to transmit that mutated copy of gene to their next generation. So depending upon the gene in which the mutant copy is there, the recurrence risk of that particular genetic disorder in the next generation, it can vary from 25 to 50%, all depending upon the inheritance of the disorder. Why screen for inherited genetic condition? Because if I get myself tested at this point of time, I may turn out to be a carrier of 1 to 5 genetic disorder. So in an average, every individual harbors an average of 2.8 known genetic recessive mutations. And these individuals, because they are just a carrier, one of the copy is mutated, other copy is working completely fine. So they don't have any disease. They're completely asymptomatic. So, previously, carrier screening was offered to the couples who had a family history of some genetic disorder, or it was previously offered to the population with a particular ethnic background in which some particular genetic disorders were more prevalent. But however, more than 80% of the babies they are born with genetic diseases to without any family history and to silent carriers. So couple carrier screenings helps us here to know the carrier status of asymptomatic couples without any family history. So carrying couple, any person who's carrying a variant is completely normal. And these variants can, when one carrier gets married to another carrier, so the mutant copy from both the parents can go to the children. And if the child is harboring both mutant copies, it can present with some genetic disorder. Family history isn't everything, because some genetic disorders they run in family, and some disorders, some mutation they occur by chance. So until unless we do the testing for a carrier status, we would never know whether some person is actually carrying the mutant copy of gene in their genome or not. And genetic disorders, they don't discriminate. They can happen at any place, at any point of time, at any corner of the world. So it's not that some like this couple carrier screening should be done in some ethnic populations. It should be done, actually, it should be offered to all couples. And individually, it may look like the genetic disorders are rare, but collectively, the genetic disorders are actually highly prevalent. So we are talking about carrier screening. So what exactly is carrier screening? So it is basically a test. It's a genetic test which is done on the DNA. The sample taken is often blood or saliva. And for couple carrier screening, there are some recommendations which are laid down by some medical bodies that it should be done in autosomal recessive or X-linked disorders. So who should get tested? Ideally, all couple planning for a pregnancy should get tested for their carrier status. But different medical bodies have laid down different guidelines. Like ACMG, it says that universal screening should be done for 113 genes. ACOG says that all pregnant women should be offered a couple carrier screening. And SIMG says that universally for these more prevalent disorder which have a high carrier frequency in India, like thalassemia, hemoglobinopathies, and SMA, they should be screened. And in expanded carrier screening, any couple with any particular family history, consanguinity, recurrent pregnancy loss, or any history of fetal malformation or any genetic disorder which remained undiagnosed in the previous child should be offered a couple carrier screening. Ideally, in consanguineous marriages, because whenever there is consanguinity, the chances of having an autosomal recessive disorder increases. If there's a history of either partner affected by a hereditary disorder, these couples should also be screened. And if there is a history of genetic disorder in the family, these couples should also be offered a couple carrier screening. And if there is a history of multiple pregnancy losses, couple belonging to particular ethnic group with higher carrier rate of some certain genetic disorders, and if there was any history of any congenital malformation, any undetected disorder in the previous child, or any undetected disorder which has been running in the family, these couples should be offered a couple carrier screening. And when should we go for a couple carrier screening? So couple carrier screening, it can be offered at different points. Preconceptional screening is one that we offer to a couple who's planning a pregnancy or who are going to get married, so they can know their status, whether they are carrying some mutant copy in some gene or not. Then comes prenatal diagnosis, which is done early in pregnancy, depending upon the from case to case scenario. We already have a couple carrier screening report with us and we know that the couple is carrying some mutation, we can do early testing by extracting fetal DNA, by doing certain procedures like CVS and amniocentesis, and we can know whether the fetus is affected or not. Then there is another scenario, that is IVF. So before IVF procedure, if a couple is going for IVF procedure for any reason, we can offer them couple carrier screening to know their couple carrier status. Then we have pre-implantation genetic diagnosis. So these are the genetic testing that we run on the embryos to know their genetic status, whether they are carrying some chromosomal abnormalities or they are carrying some single gene abnormalities. Also, there's another scenario where a couple is going for IVF through some donor sperm or oocyte. So in this scenario also, we should offer them carrier screening to know the status of the donor sperm or oocyte. So there are different testing methodologies which are used to know the carrier status of a person. So traditionally, when we used to do some targeted testing for some particular genetic disorders, so PCR-based testing and MLPA-based testing is done. Now, because we are doing testing on more than 2,000 genes, so NGS-based testing is the one which is the norm now. So NGS is next generation sequencing. It allows us to detect common and rare disease causing mutation. It has higher accuracy and low residual risk, and regardless of the ethnicity, we can report the couple's carrier status as whether they are carrier of some mutation or not. Also, these tests are integrated, like NGS is integrated with MLPA to expand the carrier screening testing to include more number of disorders. And because not just one methodology can detect everything. So because for some particular disorders, like for SMA and DMD, different kind of testing is required. For Fragile X, TP-PCR is required. So these tests are integrated to expand the horizon of the number of disorder that we are looking for. So NGS is definitely a power changing in the couple carrier screening, and it allows more comprehensive genetic analysis. It increases the sensitivity and specificity, reduces the cost. However, as we look at the cost of testing, we may think that the cost of testing is quite high, but if we want to screen for 2,000 disorders based on some previous method or some traditional methods like PCR or so, the cost of testing will go very high. So the number of genes that we are screening through NGS and the cost that we get at the end of it is quite low. And also NGS, it has a rapid turnaround time. We get the report in around 3 weeks. And if we try to do this through some traditional testing, it will take a lot of time. However, there are some limitation of NGS because variant interpretation is challenging. Sometime in the scenario where some fetal exome has been sent, so sometimes the classification of the variant and it all takes a lot of additional data and additional information to how to interpret that particular variant. And there are some incidental findings which may come in the which may one may find during the analysis, but this should be told clearly to a couple before the testing that that we may come across some incidental finding, and their consent should be taken before releasing a report if they really want to know the incidental findings or not. Data storing and analysis is again another limitation with the NGS, because the report, whoever is analyzing the report and whoever is reporting, it it affects a lot the end report of the result. So the testing process is quite simple. We just take a patient's information, their clinical information, their family history, their reproductive information, if they had recurrent pregnancy losses, previous child, if any previous child which is affected, uh, uh, death of a previous child or death in family due to some unknown disorder which has been running in the family from one generation to another. And then after taking a comprehensive history and after explaining them what exactly is the testing and what results we can get, we take the, after taking the consent, we take the sample. The sample can either be just a simple blood sample or it can be a saliva sample. Then we go for testing and then reporting, and then at the end of it, we do post-test counseling. So as we talk about carrier screening, there are different type of carrier screening that we come across. There are different kind of panels. They go by different names. So one should have a idea about what exactly are these different kind of panels. So some panels are quite limited. They are based on the family history or the ethnic background, and they test for some particular disorders only. And the expanded carrier screening panel are those which include a higher number of genes, around 2000 plus genes, and these genes are included irrespective of the patient race and ethnicity. These are mostly autosomal recessive genes which can cause some disorders, and X-linked disorders are also included in the expanded carrier screen. And in expanded carrier screening, the testing of the partner can be done sequentially or simultaneously, meaning one can either go for the testing of the mother first, because mother will can be a carrier of autosomal recessive and X-linked disorders, and further if she turns out to be a carrier of some particular mutation in some particular gene, we can test the father for that particular gene, and we can try to find if both are carrier of mutation in the same genes or not. Or we can go for simultaneous screening, where it will depend from case to case. If we are dealing with a couple who is early in pregnancy, and we can't we don't have, the time is limited, we don't have much time to go for a sequential screening. So in this case we can go for simultaneous screening of both the couple. So a majority of condition on current expanded panels are autosomal recessive and X-linked disorders. And mostly these disorders, as we look at the panel, these disorders are mostly are those which can cause cognitive disability, which need early medical or surgical intervention, which affect the quality of life. So condition for which a prenatal diagnosis can result in improvement of perinatal outcome and immediate care are generally included. The conditions which are excluded are disorders which present in an adult age, and some autosomal dominant disorders with reduced penetrance and variable expressivity are also excluded. Variants with high allele frequency and low penetrance of phenotype are excluded. And complex genetic disorder like diabetes and coronary artery disease are also excluded. So when we counsel someone for couple carrier screening, so the steps is first we go for a pre-test counseling. Before going for a test, we tell them what exactly is the testing, what kind of disorders are we looking for, and what can be the phenotype and what can be the mode of inheritance if they turn out to be carriers. And after doing a pre-test counseling, we go for the sampling. Then when the report comes, we go for post-test counseling. So in post-test counseling, all depending upon the report, what exactly is there. If the couple, both of them are carrier of mutation in same gene, depending upon whether it is an autosomal recessive or X-linked disorder. In autosomal recessive disorder, we tell them that the risk of recurrence of the disorder in each pregnancy is 25%. In X-linked disorder, the risk of recurrence is 50% in a male fetus in each pregnancy. We also counsel the couple about what exactly can be done if they turn out to be carriers. So they have multiple options. They can go for multiple reproductive options like IVF and embryo testing. They can go for prenatal testing early in the pregnancy to know the status of the fetus, whether the fetus is affected or not. And then we can talk about the possible therapies which are there for those particular disorders. And at the end of it, it's very important to tell the couple that even if the couple carrier screening report is negative for a couple, there still remains a residual risk, which we will discuss further. So the timing of screening, as I told, we can either go for a preconception screening where either there is some family history or no family history, or they belong to some particular ethnic background, or they don't belong to some particular ethnic background where some genetic disorders are more prevalent or not. Irrespective of all this history, we should take a comprehensive history. Still, we offer them that you can go for a couple carrier screening, and if they turn out to be carrier, we can tell them the productive options like IVF and PGD, and then some testing of the fetus at the time of pregnancy. Then we have another option of prenatal screening, as I discussed. So this testing can be done on the fetus. There are two procedures by which we can extract the fetal DNA, and we can do the testing on fetal DNA, and we can know the status of the fetus, whether the fetus is affected or not. So residual risk is something which is very important to communicate to a couple who's going for a couple carrier screening. So at the end of whole process, if the couple turn out to be negative for any mutation in their carrier screening, there still remains some residual risk. So residual risk is mathematically calculated by carrier frequency of that particular disorder and a detection rate of that testing. So carrier frequency and detection, based on the carrier frequency and detection rate, there still remains some risk which can still be there. So a negative couple carrier screening report does not tell that the child will never have any genetic disorder. Also, there can be some de novo mutation in the fetus which can occur at any point of time simultaneously. So couple carrier screening testing, it actually does not tells about any de novo mutation in the fetus. Again, consanguinity is one of the very important factors which affect the rate by which one genetic disorder can have in the next generation, because because of consanguinity, the genetic material of the couple is shared, so they can have same mutation in the same genes, and sharing of result of sharing of variant is one that will cause more prevalence of genetic disorder, mainly autosomal recessive disorder in that particular community, in which the consanguinity is more prevalent. So obviously, by inbreeding or or because of consanguinity, the sharing of genomic data is more, and the chances of having autosomal recessive disorder is more. So consider a variant which with a heterozygosity frequency of 1:100. The chances that the both unrelated spouses are carrier is 1:10,000. But if we look at a consanguineous couple, so if two spouses are their first cousins, the chances of both being carrier of this pathogenic variant, it goes up to 12.5 times higher. And the chances in this case will come out to be 1:100, which is much more than 1:10,000. As we talk about couple carrier screening and NGS-based testing modalities, the interpretation of the molecular findings is something which is very important. So the genes and variant included should have a very well understood relationship with the phenotype. If we are screening a gene uh, in a couple carrier screening for which the phenotype is not very clearly understood, it will be very difficult for a person to communicate the test result to the couple, and it will be very difficult for the person sitting across the table to understand what exactly is going on, what exactly is the report trying to tell. So limitation of interpretation of negative screening should be clearly communicated in a laboratory report, because as I told, that residual risk always stays, and all depends upon what exactly is the family history, which testing modality have we opted for. If we have opted for a testing modality which screens for a limited number of disorders, so obviously there are chances that we may miss some particular mutation in some other disorder, some other genes which is not included in that particular panel. And the laboratory reporting screening should report all variants that are pathogenic and likely pathogenic. And in a couple carrier screening report, VOS variant, that these are the variants of uncertain significance, are usually not reported, because this will make the clinical scenario where one is trying to give the post-test counseling or trying to discuss the report with a couple very difficult for the person who's to communicate, and very difficult for the one who's trying to understand the report finding. So all depends upon the variant interpretation for like the classification of the variant. For known, if we are reporting only the known pathogenic variants, obviously false negative results will be more. And if we are reporting all variants predicted to be pathogenic by computation analysis, so the false positive reports will be higher. As per the AGMC, so the disorder which are included in a couple carrier screening, so these disorders should be of a nature that most at-risk couples would consider having a prenatal diagnosis to facilitate decision making. So obviously, disorder which with neurodevelopment disorders, which impact the quality of life of a person. So these disorders are included. So, inclusion of disorder with mild phenotype or variable expressivity or incomplete penetrance should be an optional for these disorders. And when adult onset disorders are included in panel, individual must provide consent for the screening for these disorders. For each disorder, the causative gene mutation and their frequency should be known in a particular population being tested, so that meaningful residual risk can be assessed in an individual who comes out to be negative. And there must be a validated clinical association between the mutation detected and the severity of the disorder. As per ACOG, ethnic, pan-ethnic expanded carrier screening are acceptable strategies for pre-pregnancy and prenatal carrier screening. Ideally, these practices should be discussed before pregnancy. And all couple considering pregnancy and already pregnant should be offered couple carrier screening for at least for more prevalent disorder like cystic fibrosis, SMA, and Fragile X. And plus, they should be given an option of an expanded carrier screening. And couples with consanguinity, they should go for a expanded carrier screening to look for their increased risk of autosomal recessive disorder. And individual going for expanded carrier screening should be counseled regarding the residual risk. If a couple is a carrier is identified before pregnancy, so we can counsel them about the reproductive options, and they can have a better outcome of the pregnancy. Disorders included in expanded carrier screening should have a carrier frequency of 1:100 or greater, a well-defined phenotype, a detrimental effect on quality of life, causing neurodevelopment disorders requiring early surgical and medical intervention, and have an early onset in life. According to ACOG, these panels should not include a condition with adult onset. And prenatal carrier screening does not replace newborn screening, as there can be some de novo mutation in the newborn which can present later on in life. So as we talk about the testing methodology, so they differ with different companies. Some do whole exome sequencing, some do clinical exome sequencing. Targeted computational analysis also done, and gene panels which include different type of genetic disorders, and different number of genes are there. And as per, we can offer them to go for selective pathogenic variant analysis by hybridization method. And recently, home genome sequencing has also come up as a testing modality for couple carrier screening. Mostly that we're doing in our clinical practice is the expanded carrier screening, which includes testing methodology done by next generation sequencing plus MLPA-based testing for some of the disorders. These disorders are mostly autosomal recessive and X-linked. We can even we sequence n number of genes that depend on different panels, and mostly the expanded panels, which include most number of genes, are up to 2000s. And MLPA can be done to look for carrier status in SMA, DMD, congenital adrenal hyperplasia. We can test both the partners at once, or we can go for sequential testing. So as the report comes out to be positive for a couple for some autosomal recessive or X-linked disorder, if both are carrier for some autosomal recessive disorder, the risk of recurrence will be 25% in each pregnancy. And if the mother is a carrier of some X-linked recessive disorder, the risk of recurrence will be 50% for a female, for a male fetus. And the options that we can discuss with them is to go for embryo testing, IVF plus PGT, or they can go for fetal testing. So as we talk about IVF and PGT, so it is a modality in which we can do the testing on the embryos before the implantation. So we can know the status, genetic status of the embryos, and the embryos, those who are normal, only those embryos are transferred to the mother. So it allows a couple to select the embryos that those are free of any genetic mutation. Then another reproductive option is to go prenatal genetic diagnostics, in which depending upon the gestation, we can either go for chorionic villus sampling or we can go for amniocentesis. So chorionic villus sampling is done at around 10 to 14 weeks of pregnancy. This is a procedure to extract the fetal cells or DNA. And on this DNA or in these fetal cells, we can either go for targeted testing, or we can, if we don't have any couple carrier screening report with us, we can even go for some trio testing that includes the testing of the parents and the fetus at once. So report can show either the fetus is likely or unlikely to be affected, and all depending upon the report whether the fetus is likely to be affected or unlikely. The final decision stays with the parents. They want to continue with the pregnancy or they want to go for some other options. Another procedure which is used to extract the fetal DNA is amniocentesis, which can be done around 15 to 20 weeks of gestation. Again, targeted testing and exome sequencing can be run on this sample, and depending on whether the fetus is affected or not, the final decision stays with the parents. So we know that couple carrier screening and all these testing modalities, mainly NGS based and MLPA, it helps us to know the couple, the carrier status of a couple. And once a couple knows about their carrier status, they can make more informed decisions about their pregnancy, what exactly they want to go for, if they want to go for reproductive options before implantation or after implantation. But obviously, the accessibility of these testing and affordability of these testing is something which does not enable everyone to go for this testing. However, the cost of testing is coming down. If we compare from the last 10 years, the last 5 to 10 years, the cost of this testing has come down a lot. And interpretation of the reports and counseling is something which is again a big hurdle, because if someone comes across a report and the person does not know how to interpret the report and how to counsel the results, so the whole exercise becomes futile. So meeting someone and getting a consult from a person who is well versed with the interpretation of the report and how to counsel about the report is paramount. Again, there are some ethical consideration in the couple carrier screening, like incidental findings, whether we need to disclose these findings or not, whether we have already counseled the couple about these kind of findings, and should we disclose the findings or not. And then again, the reproductive decision making is something that we can only tell the parents that you have these options, and they can go for either option, whatever they are more comfortable. Then I think the onus lies on the medical fraternity to educate and aware the parents about the communities about the incidence and prevalence of genetic disorder, how can we prevent them to occur in the next generation. And obviously, standardization and regulation of this testing is something which is very important. So the take-home message is the couple carrier screening is a valuable tool that can help couple make informed decision about their reproductive health. Early identification can relay anxiety. They can help them to make better decisions. They can help them to go to their physician to know what options they have. And once we are able to pick up the disorders, once we are able to know the carrier status of the couples, and if they go for these reproductive options where they do not where they completely end the genetic disorder at that point only, and only normal embryo or normal fetus is carried on in the pregnancy. So this will decrease the burden of genetic disorder, not just in the population, also the financial burden for the family. So imagine a disorder like SMA, for which the cost of treatment at this point of time is a gene therapy, which cost around 16 crores. So if we are able to detect this disorder, if we are able to pick the carrier status of a couple at a very early point of time, and we can completely end the cycle of this disorder. So obviously this will decrease the financial burden on the parents as well. And I encourage through this webinar, I encourage the healthcare provider to offer carrier screening at a part of their routine prenatal care and to promote public awareness about the benefits of carrier screening. Thank you. Do we have any questions in the chat box?
No, doctor, as of now, there are no questions. Audience, if you have any questions, you can please type it on the Q&A window and we'll be very happy to address them. Dr. Beenal Shah wants to understand what is the cost, approximate cost of carrier screening in India specifically.
So the cost of carrier screening, it all depends upon what kind of testing are we picking up. Are we picking up some limited carrier screening, or are we picking up some expanded carrier screening? Or what exactly is the case scenario? If there is some history of some genetic disorder in the family and the mutation is already known, then obviously the cost of testing will go down. But obviously, in a couple with a consanguineous marriage, there is chances that more of the genetic material will be shared depending upon the degree of consanguinity. So in such cases, we can give them option of expanded carrier screening. So if we are screening a couple for disorders with a higher carrier frequency in a population, like as we talk about northern Indian populations, the carrier frequency of thalassemia, SMA, cystic fibrosis is quite high. So obviously, if we are screening less disorder, the cost will be lesser. If we are going for expanded screening, which include autosomal recessive X-linked disorder, and by doing NGS plus MLPA, the cost of testing will be higher. And different labs, they offer different costs. So one can just go through their panel, what exactly are they offering, and if the panel is sufficient for that particular case, we can choose whatever panel is there.
Thank you, doctor. Another question that we've received from Dr. Mansi Vishal is, if carrier screen test comes negative, what prenatal genetic test should still be considered if the couple is interested?
So this will depend from case to case. First, we talk about a case where there is no family history, there is no recurrent pregnancy losses, they don't belong to a particular ethnic group where some risk of some genetic disorder is quite high. So if at this scenario, with this scenario, if the couple carrier screening test, which if I assume it's expanded carrier screening test, which screens all autosomal recessive and X-linked disorder, comes out to be negative, we can just counsel them that there still be some residual risk, all depending upon the carrier frequency and detection rate of the testing. There still be some residual risk, but we're just looking at their report. If it is negative, they have a very low chance of having any genetic mutation in the child. However, a risk of a de novo mutation is always there. So newborn screening is another kind of testing that we do at the time when the child is born. It's a completely different type of testing which will look for a de novo mutation in a newborn. If the couple is not a carrier, there still be chances that the child can have some spontaneous mutation by its own.
Thank you, doctor. So another question from Dr. Ankit. Who should get screened? People with a family history of genetic disorders or those with certain ethnicities? Or should we consider universal carrier screening?
So to answer this question and to choose what to go for, we should have a data of a population which genetic disorders are more prevalent in that particular population. So in the Indian scenario, as we have limited data of carrier status of Indian population, we should go for a testing that includes everything that like if there is no family history of genetic disorder, still we should give an option for this couple to go for expanded carrier screening, because we do not have the prevalent carrier frequency data of Indian population for all the disorders with us. So we may miss out their carrier status. Sorry, you're not audible. You're not audible now.
Yeah, I was on mute, sorry. So thank you, doctor. Like we understood that for some genetic conditions like SMA, DMD, and CH, we need an additional panel of MLPA. Is CH, when we are offering expanded carrier screening, do we have to offer CH as a de facto, even if the history of congenital adrenal hyperplasia in the family is not there? Should it be included in all carrier screening panels, or it's optional?
Yeah, it should
That's
be
the
included in
question
all
from Dr. Mishra.
screening. Yeah, it should be included in all screening panels, because it being an autosomal recessive disorder, so there can be 25% chances of risk and recurrence. And for CAH, MLP is another methodology which should be used, because there can be some deletion duplication which can be missed on NGS-based testing.
Noted, doctor. Thank you. So another question from Dr. Tejaswarim Toleti. Respected madam, how detailed pedigree can be necessary for analyzing carrier screening if the family has different
Hello? Hello?
Yeah. So Dr. Richa, I think we lost the connection for a while.
Yeah.
The question was, how important is a detailed pedigree in analyzing families where there are certain genetic disorders already there, like hearing loss or autism, for doing a carrier screening in the family?
So pedigree helps us a lot to know about the inheritance pattern of a particular disorder. Like in autosomal recessive disorders, many of the hearing disorders are autosomal recessive. So in these cases, the pedigree will show that there is autosomal recessive disorder going on. The consanguinity, if there is a history of consanguinity, the chances of autosomal recessive disorders will be high. And if multiple disorders are running in a family, all depending on what kind of disorder it is, what kind of inheritance pattern the pedigree is showing, we can go for testing as per the pedigree, what information the pedigree is giving us. If it is giving us an information of what's the autosomal recessive inheritance or autosomal dominant inheritance. But when we talk about couple carrier screening, we are mostly talking about autosomal recessive disorder and X-linked disorders. Autosomal dominant disorders are mostly not included in the couple carrier screening, because in autosomal dominant disorders, the particular person who is carrying the mutation will manifest with the disease. And in autosomal recessive, in autosomal dominant disorder, there will be 50% chances of risk of recurrence of that disorder in the next generation. And in autosomal recessive, there will be 25% chances.
Yeah. Thank you, doctor. Just one question from my side. I think the audience questions are over. When should we consider a couple for a chromosomal microarray testing, and why?
Chromosomal microarray testing of a couple.
Yeah.
Okay, so CMA is a test which looks for whole chromosomal abnormality as well as microdeletion and duplications. So it is a comprehensive test that includes all kind of abnormalities which can be there in a chromosomal disorder. So when we go for a karyotype, we look for a whole chromosomal abnormalities or any deletions which are very big, more than 5 MB, which can be picked on a karyotype. But chromosomal microarray will look for micro deletion and duplications as well. So if in a couple whose karyotype is normal and still they have some, and the fetus has some micro duplication and micro deletion, so we can go back to the parents and do their CMA testing, and couple karyotype is normal, and we can do their CMA testing to know whether that particular micro duplication or deletion is inherited from the parent, or that particular deletion duplication has come by de novo in the fetus. So in that scenario, the testing of couple becomes very important. And there may be some disorders which may have a very subtle phenotype, which may be missed on doing some clinical examination or taking some history. So there are chances that the fetus has some microdeletion duplication which was inherited from the parent, and the parent has a very subtle phenotype. So we can always go back and do the testing of the parent, and as per the CNV, we can just go for detailed phenotyping in the parent as well.
Understood, Doctor. Thank you very much. I think there are no more questions. So we can conclude the session. So on behalf of Unigenome and the audience and our lovely audience, we thank you, Dr. Richa Soni, for such an insightful and engaging session. Your expertise in the field of genetics is truly inspiring, and the valuable knowledge that you have provided during this session would definitely play a pivotal role in helping reproductive specialists to make informed decisions in their clinics as to when and how to offer carrier screening. We sincerely appreciate your time and effort in making this webinar a success, and we look forward to future collaborations and learning opportunities from you. Thank you once again, Doctor.
Thank you so much.
Thank you. Thank you, audience, for your attendance. Thank you. We'll end the session now.